I'm Dr. Louise Newson, I'm a GP and I also run a menopause clinic in Solihull, West Midlands. I'm also passionate about trying to demystify the menopause and HRT and trying to educate people so they have the right facts and the right information, because the menopause should be a new chapter in our lives. It should be something exciting. We've potentially got 30 years of living with the menopause, so we need to embrace it and enjoy this time of our lives. So the menopause basically means when your periods stop. It means that you haven't had a period for at least 12 months. The reason that people have a menopause is because your ovaries stop working. Usually it's naturally, so your ovaries run out of eggs. You only have a certain number of eggs, and when they stop being produced, you stop having your hormones, and that causes menopausal symptoms. Some people have a menopause because their ovaries are removed in an operation, or they're damaged by certain drugs or radiotherapy. So there are different reasons why people have menopause. There are many different symptoms of the menopause. Some women are really lucky, so around 1 in 5, 1 in 10 women don't have any symptoms of the menopause at all, and they're very lucky, but they are the minority. Most people have symptoms, and a lot have symptoms that interfere with the quality of their lives. The common symptoms that people think about are hot flushes and night sweats, and these can occur very frequently and very often and really disturb your function in the day and also at night time. But there are other symptoms, and these are the symptoms that affect my patients more. So symptoms, the psychological symptoms such as low mood, low self-esteem, loss of memory, concentration problems. You go into a room and you can't remember what you've done, or you can't find your car keys, and that can affect your ability at work as well. Some people find that their skin changes, so their skin can become very dry and itchy. Some people get this thing called formication, where they feel like little spiders crawling on their skin, and that can be associated with lack of estrogen. Some people notice that their hair changes, their skin changes, nail changes. So there's lots of negative symptoms that can really affect the way that we live, and not many people know that these symptoms are related to lack of estrogen. We have estrogen receptors in lots of cells all over our body, and that's why the symptoms can affect us in so many different ways. The other thing that people find is that it can just affect their energy and their drive. So most people find that they have far less energy than they used to, so then it's more difficult to carry on doing sports, exercises, things that they used to do before they started getting symptoms. Because we have estrogen receptors in our blood vessels and also our hearts, it can affect our hearts. So some people find that they get palpitations, some people find that they even become short of breath. Some people find that they get joint pains and stiffness as well. I see lots of people that have been seen by rheumatologists thinking they might have arthritis, but actually it's related to the lack of estrogen, because it's very important for the collagen and also the way that our joints move and have fluid within them. So making the diagnosis of the menopause is actually very straightforward. It is usually a clinical diagnosis, which means it's talking about the symptoms and the doctor collecting the symptoms together and making the diagnosis. The guidelines are very clear, so if someone is over the age of 45, they don't need to have blood tests. They can be diagnosed on their periods changing in nature and having symptoms. If they're between 40 and 45, then sometimes we do blood tests, but often we still go just on their symptoms alone. Women are under 40 years of age normally do have to have hormone tests. So for the majority of women that I see in general practice, I can diagnose and then I can get on and treat and talk about how to manage their menopause. The symptoms of the menopause really vary. Some people don't have symptoms, some people only have symptoms for a few months, but the average length of time is about 4 years. But we also know that around, even some studies have said 50% of women have symptoms more than 10 years. And I certainly have some patients in their 70s and 80s still having hot flushes. There's no way of determining how long your symptoms are going to last for. So it doesn't correlate with how long your mother or your sister might have had symptoms for. So unfortunately, you don't know how long they'll last for and which symptoms they will be. Some people find that even when their symptoms improve, the symptoms of vaginal dryness carry on, so you can still have symptoms, although you've got over the worst part, if you like. So perimenopause Peri is a word that means around, so it just means around the time of the menopause. So often women find that even 3, 4, 5 years before their menopause, they start experiencing menopausal symptoms, even though they're still having periods. Usually periods change. For most women, periods become lighter and less frequent, but for some women, periods can become closer together and heavier, which is a real nuisance. And then people get menopausal symptoms as well. So once the menopause starts, or once you've had 12 months without your period and you're menopausal, then you become postmenopausal. And these are all terms really, because whether you're perimenopausal, menopausal or postmenopausal, you still have similar symptoms often. So although the average age of the menopause in the UK is 51, we know around 1 in 100 women under the age of 40 have an early menopause, something called premature ovarian insufficiency, or POI. Often we don't know why this happens. The eggs run out earlier than in other women, so people develop the menopause early. For some people it can be a genetic condition, so it can run in families, or it could be because they've had an oophorectomy, they've had their ovary removed by an operation, or received some drugs like chemotherapy or radiotherapy affecting their function of their ovaries. So not only does it affect 1 in 100 women under the age of 40, it affects around 1 in 1,000 women under the age of 30. It's very important that these women are diagnosed and also have hormone treatment, either in the form of HRT or the combined contraceptive pill. And the reason being is that our bodies are designed to have estrogen till at least the age of 51, the natural age of the menopause in the UK. If women don't have hormones when they're young, then they have a far greater risk of heart disease, they have a far greater risk of osteoporosis, dementia, but giving hormones reduces this risk. So it's very, very important that they seek the right medical advice. Some women with premature ovarian insufficiency have reduced fertility, and actually there is some evidence that taking hormones improves this fertility. So it's another very important reason that people are diagnosed. So in addition to having all symptoms of the menopause, there are actual health risks to our bodies of not having estrogen. If you think back to the 1900s, the average age of the menopause was 57, it's now about 51. And in the 1900s, the average age of death was 59, so we only had a couple of years living without estrogen in our bodies. Now we have about 30 years, which is fantastic. Obviously we live longer, but then we have a long time without estrogen. Estrogen is very important for lots of reasons, but mainly it is very important for our hearts. So when we go through the menopause naturally, we have a 5 times increased risk of a heart attack. And this is because we don't have the estrogen protecting our bodies. We also have a far higher risk of osteoporosis because we need estrogen to keep our bones strong. So without estrogen, we have a far higher turnover of bone loss, which makes our bones thinner, can lead to something called osteopenia, which is thinning of the bones, and then osteoporosis. And we know around 1 in 2 women, so 50% of women over the age of 50 will have a fracture because of osteoporosis. So there are lots of taboos about the menopause, but a very common taboo is talking about vaginal dryness. And because we have estrogen receptors lining our vaginas and also in our urinary tract, so in our bladders, in our urethra, which is the tube lining your bladder, people find that they have a lot of symptoms down in that area. And one of the very common symptoms is vaginal dryness. We know that around 70% of women have it. It's one of those symptoms that often gets worse even when menopausal symptoms improve. And it can cause a lot of irritation, soreness. Lots of people find that having sexual intercourse is difficult, but also people find that it can affect the way they work. Even sitting down can be uncomfortable. Some people have to change that they can't do sport. I've had patients that can't put on swimming costumes, they can't wear wetsuits, and they used to do triathlons. And it can cause a lot of discomfort and a lot of embarrassment. And people have been very embarrassed to talk about it, so not getting the right treatment. Because we've got estrogen receptors in our urinary tracts as well, people find that their bladders can't hold urine the same that they used to, so they find they've got increased frequency of going to the toilet or urgency. So you put your key in the door after coming back from shopping and you have to run to the toilet. And that's because without estrogen, our bladders become more irritable and more, it's harder to, like I say, hold on to urine. So people find they have more accidents. This, on top of having other menopausal symptoms, can really affect the way that we live. So vaginal dryness is a very common symptom related to lack of estrogen, and it can cause a lot of symptoms that can really interfere with people's lives. We know around 70% of women have vaginal dryness, and only about 7% of women have treatment. The treatment's very simple when you get it right. So one of the treatments that can help is taking HRT, and that can help if people have other menopausal symptoms as well. For other people, we often give local estrogen. So this is estrogen as little tablets for the vagina, or it can be cream, or it can be a ring, and the ring can last for 3 months. Having estrogen back in that area thickens the vagina so it becomes more moist and it's less uncomfortable and doesn't cause symptoms. Because the lack of estrogen can also cause urinary symptoms, such as going to the toilet more often and more frequently, or having inability to hold on to urine in the same way, having local estrogen really improves the urinary symptoms as well. So people find their lives become so much better when they have the right treatment. The other treatment we often use is vaginal lubricants and moisturisers. So there are lots of different products on the market. Some of them can be very irritating and drying and actually cause worsening symptoms. So it's very important to have some proper advice about the right treatments. The moisturisers can be used regularly, and the lubricants are used when you have sexual intercourse. But having the right treatment can make a huge difference. The main treatment that works the best is hormone replacement therapy, HRT. HRT comes in very different ways, different forms, different doses, and it can cause a lot of confusion. The main hormones that we produce that we need, that are lacking in the menopause, are estrogen, also testosterone as well, and there's progesterone too. Estrogen and progesterone work very well to help with our periods when we're younger. Without the estrogen, that causes the majority of symptoms. So certainly the vasomotor symptoms, the hot flushes and night sweats, but also some of the other symptoms too. So estrogen is the main component of HRT. People who have still got their wombs, so haven't had a hysterectomy, still need progesterone to protect the lining of their womb as well. So estrogen can be given as a tablet. It can also be given as a patch or a gel. And I recommend a lot of my patients to have it through the skin as a patch or gel, because when it's absorbed through the skin, there's no risk of a clot, because it doesn't activate your liver clotting factors, so it's a lot safer, and you can tailor make the dose depending on the woman. Because it's very important with HRT that people have the right dose and the right type. Everyone's different and everyone should be treated differently as well. So there's the estrogen part and then the progesterone part. And that can be given usually as a tablet, and there are different types of progesterone. And some people have what's called a Mirena coil, which is a contraceptive device, and it's a little coil that releases progesterone, so they don't need to have additional progesterone with that as well. The other hormone is testosterone. Everyone knows testosterone because it's a male hormone, but we actually produce about 3 or 4 times more testosterone than estrogen before our periods stop. Testosterone is very good for our libido, so our sex drive, but it's also very good for mood, energy, concentration as well. So a lot of people who take HRT still find that they're lacking some of their libido, but this sort of mental energy, this mental clarification often goes as well. So people often benefit from having testosterone too. So there are many benefits from taking HRT. The main one is that people get their lives back, symptoms go, because you're treating the underlying cause. If you're giving estrogen and sometimes testosterone, you're replacing the hormones that our bodies haven't been producing. So people find their symptoms improves, especially the hot flushes and night sweats, their lack of concentration. It can improve the depressive symptoms related to the menopause as well. Skin can get better, hair can get better, the list goes on, but it will make people better, which is great. And for me as a doctor, it's fantastic to be able to make people feel better. The other thing that a lot of people don't realise is that for the majority of women under the age of 60, the benefits of HRT outweigh any risks. When we look at risks of HRT, people are always worried about breast cancer, and that's the main reason that people don't take HRT, which I can talk about in a minute. But the benefits of HRT Because you're giving estrogen, you're helping protect your bones. And estrogen is the best treatment at preventing and also treating osteoporosis. And osteoporosis occurs when the bones thin and become more likely to break and fracture. So we know the earlier people are given estrogen, the better it is for their bone density. The other thing that's very, very important is that having estrogen early reduces our future risk of a heart attack. Cardiovascular disease, so that's heart attacks, strokes, is the number one killer really in females in the UK. Taking estrogen within 10 years of the menopause reduces our risk of a heart attack, and it's very important that people realise that. If you take it early, it helps keep our blood vessels healthy because the estrogen works to keep our blood vessels open. It can also help lower cholesterol, which is very important because high cholesterol levels can increase the risk of heart disease. We also know that when you take estrogen early, it reduces your future risk of type 2 diabetes, which is obviously a very important disease, and that can increase your risk of having a heart attack. There's also some work that having estrogen early can reduce future risk of dementia. There's various studies, but it does look that there is a protective effect of estrogen on our brains as well. So there are many different guidelines that we use as healthcare professionals regarding menopause and HRT. The main one is the NICE guidance, the National Institute of Health and Care Excellence, and these were produced in November 2015. We also have International Menopause Society, IMS guidelines, and the BMS, so British Menopause Society guidelines. And these are very good for healthcare professionals and also patients, women, to read to understand how safe HRT is. So HRT is made from different things. In the past, the estrogen was made from pregnant horses' urine, and some types of HRT still are. I have lots of patients that are on the horse's urine HRT without any problems. Thankfully, HRT now is made usually from a yam, which is a root vegetable. So the natural estrogen and the progesterone can be made from the yam, which means it's a lot more natural, it's not synthetic, and it is a sort of body identical, so it's the same molecular structure as the hormones that we produce ourselves. There's no maximum length of time for which you can take HRT. The most important thing to know is that when younger women have HRT, they have to take it until at least they're 51, the average age of the menopause. We also know that for women under the age of 60, the benefits of HRT outweigh the risks. So most people are on HRT for at least 60. After this age, it's an individual choice. There are no guidelines that stay a maximum age that you have to stop HRT. So I have a lot of patients that carry on HRT because they like the heart protection and the bone protection and also the way it makes them feel. Some people come off HRT and they can usually come off very slowly and see how they feel. The problem is that symptoms of the menopause can last a long time. So if, for example, someone was taking HRT for 5 years, but they were going to have 10 years of symptoms, they've still got 5 years of symptoms left. So coming off HRT does not give you a menopause. It will unmask symptoms that your body will otherwise be producing. Testosterone is a really important hormone for men and for women. In women, we produce more testosterone than estrogen before the time of the menopause. And testosterone is very important for our libido, so our sex drive. It's also very good for mood, energy, concentration. In addition, it helps with our bone strength and our muscle strength as well. Some people find that without testosterone, even with having the right type of HRT, they're still suffering with some symptoms. So people find that taking testosterone can make a big difference to the quality of their life. Testosterone in the UK isn't licensed in women, and this is just a marketing reason. It's not because of safety. When you look at the data, testosterone isn't associated with any type of cancer, which is good. And like I say, it can help with bones and it can help with muscles as well as improving symptoms. So when we prescribe testosterone, it's given as a small tube, and we just make the tube last around 10 days to 2 weeks. So it's a very small amount of gel that is put onto the skin. Some doctors give it as implants, but most doctors give it as the gel. So most people, when I talked about HRT, are scared about HRT because of this breast cancer risk. And unfortunately, some of the newspapers haven't helped with portraying this risk. So with breast cancer, there's a few very important points. One is, if you're under 51 and take HRT, then you don't have an increased risk. So certainly young women who take HRT, they are just simply replacing the estrogen that their body would otherwise be producing. So there is no increased risk of breast cancer. For people that have had a hysterectomy, so have had their womb taken out by an operation, they only need estrogen, they don't need progesterone. Having estrogen only HRT, there is no increased risk of breast cancer. So those women, if you like, are lucky, they don't have any risk to worry about. For people who still have their wombs and need to have estrogen and progesterone, the studies have shown that it's the progesterone that has maybe a risk of breast cancer. It doesn't initiate, so it doesn't start breast cancer, it seems to proliferate cells, so make cells grow that would have been there anyway. But if you look at the worst study over the worst length of time, it shows that the risk of breast cancer, if you take HRT for more than 15 years, the risk of breast cancer is around 3.3 times, which sounds a lot, but actually when you compare it to other things that increase our risk of breast cancer. So if you look at drinking, if you're drinking 2 glasses of wine a night, then your risk of breast cancer is higher than taking the worst type of HRT for more than 15 years. So I see a lot of women in my clinic who feel rubbish because of their menopausal symptoms. And because of this, they're not exercising. That increases their risk of breast cancer. They're drinking wine to try and get them to go to sleep. That increases their risk of breast cancer. They're comfort eating because they feel awful. So they're putting on weight, so they comfort eat more. Vicious cycle. Being overweight or being obese increases your risk of breast cancer far more than taking HRT. So you can see where the conversation is going. A lot of women take HRT, they feel better, so they reduce their other risk factors of breast cancer anyway. There is some newer types of progesterones. There's a natural micronized progesterone, it's called, which we think doesn't have this association with breast cancer. But when you look at the figures, it's a very, very small risk. And I often say to patients, we cross the road, we take a risk. We get in the car, we take a risk. You're far more at risk having a car crash when you drive than you are getting breast cancer taking HRT. The other risks of HRT is one of a clot. So when people take estrogen orally, so as a tablet, there's a very small increased risk of a clot. When you look at the figures, it's around double, but your background risk is usually quite low of having a clot. So there is this small increased risk of a clot. However, if you have estrogen through the skin, so as a patch or a gel, there's no increased risk of clot because you're not activating your liver clotting factors, which you are when you take a tablet. So it's very important that people know there's a difference between the different types of estrogen. Many people find when they go through their menopause and perimenopause, because of the changing hormones, they put on a bit of weight to have this sort of central spread, which can happen because of the hormones changing. Actually, taking HRT doesn't make people put on weight. There's this fallacy that it can. When you look at the studies, both groups of women tend to put on weight, whether they're on HRT or not. And this is just because our metabolism changes as we get older. When people have HRT, it often helps improve, obviously, the balance of hormones and also makes people feel better. So most of my patients in clinic actually lose weight. It's not a direct effect of the HRT, but it's a fact that they're feeling better. So then they look at their diets. They reduce alcohol, which is often fattening. They also exercise more. So actually, people shouldn't not take HRT because they're worried about their weight. Some types of progesterones, so especially the older types of progesterones, can be associated with some fluid retention, so people feel a bit bloated. And this can be very easy changed by altering the type of HRT. So there are some women who don't want to take HRT or can't take HRT. There are some medical reasons why people can't take HRT. But HRT is only one part of the jigsaw, if you like, of helping menopause. It's not just having HRT and not thinking about everything else. It's very important to use the menopause, I think, as a time to reflect and think about your future health. So looking at your weight, looking at your diet, looking at your exercise. If you smoke, you should not smoke, because we know that smoking increases the duration and severity of hot flushes. Drinking alcohol, obviously, it's worth looking at that as well. So lots of people find that just modifying their health can make a big difference to their symptoms, but also their well-being and their future health as well. Having some foods can improve. There are some foods that contain something called phytoestrogens, which can stimulate our estrogen receptors. So these are foods like pomegranates, some mung beans, some types of cheese, but you have to eat a lot for it to really make a difference. Some people find that they don't want to take HRT and they're very adamant when they see me in the clinic, but it's usually because they don't know enough about it. And so it's very important to have the right facts and the right information before you make a decision. Some people are worried and they want to have natural products. And I think this is very difficult because to define what natural is, it can be quite hard. There are lots of plants that are very dangerous. So some people take some herbal preparations and we don't know how safe they are. There's not good evidence that they work, which doesn't mean they don't work, but we don't know how safe they are. So it's very important that you get right advice before you take some of the alternative treatments. Some of the alternative treatments might help symptoms, so they might help hot flushes, they might help night sweats, but they won't help reduce the risk of heart disease and reduce the risk of osteoporosis, which HRT clearly does. Bioidentical HRT is a type of HRT which is supposedly tailor-made for the woman. It contains different hormones, but the thing about bioidentical HRT is it's not regulated, so we don't actually know what's in it. There's not good evidence that it works, and some of the products can be potentially harmful. So a lot of people who have bioidentical A lot of people that have bioidentical HRT are having estrogen and they're having progesterone, and some of them are having testosterone as well. So a lot of what they have is similar to what we prescribe in the NHS, but they are also given other hormones. So certain hormones like DHEA, which is a precursor for testosterone. Some women are given thyroxine when they've got a normal thyroid function test, so they don't really need it. Some people are given steroids as well. The other thing that sometimes people are given is progesterone creams. Now, progesterone doesn't get very well absorbed in the skin, so we don't know how well it is protecting the lining of the womb, which is the reason someone needs to have progesterone. Because these products, we don't know what's in them, the National Institute Health and Care Excellent guidelines are very clear, saying they're not regulated, they're not recommended. So you just have to be very careful to know what you're taking. So menopausal symptoms affect us at home, but they can also affect us at work. The common reason that my patients talk about giving up work or changing their work is because of the psychological impact of the menopause. So it's the loss of concentration, it's the irritability, it's the low mood, it's the anxiety, it's the poor memory. Symptoms like this that a lot of people don't even realise are related to their hormone levels, and certainly a lot of their employers don't realise. Sweats can be very debilitating, can come at all sorts of times, and hot flushes as well. So it's very important that menopause is not a taboo in the workplace, so that people can engage and talk to their line managers and have the right support and information at work.